Students, we're now going to be looking at various abnormalities related to your gait. We will begin with normal gait. Normal, so we will ask the patient, Marcel, can you just walk normally down to that chair? No, just walk normally. So in evaluating the gait, we look at the stride length, which is the distance between the patient's steps. And usually they're on average about shoulder width apart in length. We also look at the base of the patient. Most patients have a narrow base wherein the longitudinal axis of their feet do not stray outside of the width of their shoulders. Perfect. Also, as it relates to the gait, the patient's arms move fluidly at their side. So turn and walk. So we will note that this patient has a normal stride length. Their stance is narrow and the arms move fluidly at their side. Perfect. In some patients, for example, who have cerebellar disease, what is known is that their stance becomes very wide. And so the patient assumes a wide-based gait. Marcel, just spread your legs apart just a little more than shoulder width apart. Keep going. Keep going. Right. And the patient, when they walk, they maintain that wide base stance. So can you turn around, keep your legs apart as you walk, far apart. Further than that, Marcel. Right. And oftentimes with cerebellar disease, the person sways or staggers from one side to the next and oftentimes falls preferentially to one side. And that is the hallmark of cerebellar disease, a wide-based gait, ataxic gait, oftentimes falling to one side. The other gait is called, Marcel, so this is the one where I need you to lift the toe last off the ground when you're walking, okay? The other gait is what's seen in patients who have a peripheral neuropathy with a foot drop, for example, a unilateral foot drop, where the patient has a high stepping gait where the toes are almost dragged along the floor. Marcel. The toes are the last parts of the feet to be lifted above the ground. And this is seen in a patient who has a peripheral neuropathy. And that is called a high steppage gait. Now finally, or no, not finally. Another example as it relates to gait is what is seen in patients with an upper motor neuron lesion, for example, a stroke. What is seen is adduction of the involved limb with flexion at the elbow, flexion at the wrist, and flexion of the fingers. That is the posture of the upper extremity. However, in the lower extremity, the patient has extension at the hip, at the knee, and at the ankle, and circumlocution of the leg. Right. And so in patients with upper motor neuron pathology, on ambulation, on ambulation, there is circumlocution of the lower extremity. And the hand is kept close to the body elbow flexed, wrist flexed, as well as the fingers. Perfect. Okay. Final example is in patients with extrapyramidal involvement, for example, various Parkinsonian syndromes like Parkinson's disease. Usually what is seen is a patient has a stooped posture, that the base of their stance is very narrow, and they take short, festinating steps. Of note, they have reduced arm swing, and when they turn en bloc, and we will demonstrate this now. Marcel, can you just turn? Turning en bloc, and then walk quickly in rapid, short, festinating steps. Note there is decreased arm swing. Can you turn for me, Marcel? Notice the patient turns in minute segments in a 360 degree, and that is called turning en bloc. Usually, when someone is walking normally, they turn quite fluidly, usually beginning with their upper trunk, with their trunks, like this. That's how we walk normally. Okay. The last maneuver is doing what's called tandem walk, where the patient is asked to toe a line and to put one foot directly in front of the other. Usually this is a function of both dorsal column health as well as cerebellar health. And so in patients who have dorsal column disease, what is noted is that they have an inability to perform this task. If the patient has unilateral cerebellar hemisphere disease, what will be seen is that the patient will fall preferentially to the side of the cerebellar lesion. We will also end with what's called the Romberg's sign, and this is another test for dorsal column health, where the patient is asked to stand about just short of shoulder width apart, straight and tall. The arms are outstretched, usually with the palms facing up, and then the patient is instructed to close their eyes. Close your eyes, and a person with normal, healthy dorsal column function is able to maintain this posture indefinitely. For patients, however, who have dorsal column disease with impairment in proprioception and joint position sense, what is seen is that the patient sways and sometimes falls backwards. And this is called a positive Romberg's sign. So thank you for participating in the performance of the gait and coordination. Please practice, as these tools are important. Thank you.